So I don't have any disclosures. I'm not going to be talking about any experimental treatments or medications. What I'm going to cover here is, for the next hour, is to review the concept of live donor liver transplantation, and then also to recognize issues that are specific to living donation that we don't see in the general deceased donor liver transplant realm. So this is what I'm going to cover from start to finish. We'll start with the background and the indications. How do we select donors, evaluate them, also matching them with the recipient, size matching, technical considerations, the outcome of live donor liver transplant, and ongoing challenges. So you have heard something similar in a lecture earlier this past summer regarding how liver transplantation came about with the success of kidney transplantation, and then there were always attempts to do liver transplantations in fits, but didn't really take until the 1970s when cyclosporin was discovered and utilized, and then started doing deceased donor liver transplants, and with the success of that, moving on to live donor liver transplants. So the first successful one was done in 1989 in Australia, involving the donor was a mother to pediatric to an offspring. So I'm going to be using some abbreviations, acronyms. So OLT will stand for orthotopic liver transplantation, which is our typical deceased donor liver transplant. So things to consider when we're evaluating somebody for liver transplantation is, one thing that we need to be aware of is that we do have limited resources where donors are concerned. So we're going to look at what the patient's risk of survival without transplant and quality of life without transplant is, consider whether would they benefit more from a liver transplantation. Other things to consider also is that transplantation itself is not magical. A lot of things happen during and also after post-transplant care that where we also have to look what are the chances of the patient surviving after undergoing a transplant, and also what the person's quality of life is after transplant, and whether doing this type of surgery will make a difference in that person's life afterwards. So even though, Zach here, I'm going to say, okay, we're talking about old slides. So I know it's 2006. Unfortunately, it hasn't, and what's sobering is that it hasn't really changed. People on the waiting list and people who actually get a transplant, there is still that big gap to traverse. I just want to point out over here, the big change here is this is when we switched the allocation methods from just waiting time to switching it in early 2002 to the MELD scoring system. So a lot of people didn't actually need a transplant were taken off the waiting list because their MELD scores weren't high enough to warrant that a transplant would make a difference for them. So the problem here is that we don't have an infinite supply of organs or livers. So some factors come about over the years is that there's an increasing awareness of liver disease. What I always like to bring about is in the late 1990s, it seemed like there was this epidemic of cirrhosis or hepatitis C went around. It was because insurance plans were starting to require people to be tested to check for chronic liver disease, hepatitis C. And so a lot of people were getting referred more than before. Also increasing frequency in diagnosed liver disease. And one example I use here with people who live long enough to develop complications of chronic liver disease is the appearance and the utilization of antiretroviral agents for HIV. Before the availability of these antiretroviral agents, we didn't see, and I know that because I'm from that generation, we didn't see people with HIV live past 40 years of age. And so once that came in, those therapies became available, we started seeing these patients live long enough to manifest chronic liver disease and decompensated liver disease. So how ways to, this is what I'm going to segue into live donor transplant, is how do we solve the organ shortage, or at least answer part of it, is by looking at expanding beyond the use of whole organs. So we're looking at deceased organs, organs from deceased donors in partial size, such as split organs, like splitting one whole liver recipients. Also looking at another partial organ size would be the use of live liver donors. So we've also looked at using whole organs but marginal in quality. So these are grafts not usually considered optimal in quality if we could pick and choose. So we're looking at definitions of marginal organs, include organs with prolonged ischemia time, fatty livers, organs coming from older donors, donors with viral hepatitis seropositivity, such as those previously exposed to hepatitis B and hepatitis C, or may even still have these viral infections ongoing at the time of the donor's demise. So split liver transplant was a partial solution to the problem of organ shortage, looking theoretically at a graft being split into two parts and given to two recipients. Looking at, since we were looking at the size would be dividing the liver into the left lobe and the right lobe, with the left lobe taking about 1/3 of the entire volume. So theoretically would go to somebody of smaller stature, such as a pediatric patient, and then the bigger lobe going to an adult recipient. And the studies observations showed that survival rates were similar to those receiving whole organs from deceased individuals. So this would just be an illustration about surgical division. So none of these, including with live donors, none of these divisions are set in place. These are all man-made divisions, so made by the surgeon in the operating room. So in the beginning, so we're looking at the reference here from the mid-1990s. We're looking at with split liver that the number of transplantable grafts increased by 1/4 when using split grafts. And the greatest impact would be applying it to adults, because even though children or pediatric patients do undergo liver transplants, they comprise a very small percentage in the whole pool compared to just adults. So now we come into liver donation. I mentioned earlier that the first successful one was done in 1989. And then from there, based on our experience and also experience with other centers, particularly in parts of the world where allocation for diseased livers may not be successful, or perhaps with cultural or religious beliefs that prevented people from donating. And so these are countries where living donation became the norm, or at least the majority of liver transplants. So we could see that from originally live donor transplants were just done from an adult donor to a pediatric recipient, and then because of these experiences with other countries and other centers, found that you could do living donation between an adult donor to an adult recipient. So initially, again, things were done cautiously because there were no rules to guide anyone. So initially, only left hepatic lobes were used, and then after that, it was found that you could use the right lobes in a safe manner as long as the situation was screened very carefully. So the first United States series of right lobes were reported in 1998 and 1999. And currently about 7,000 of these live donor liver transplants have been performed worldwide. So you probably notice with the references, a lot of them from the 90s, was because a lot of research was done in this time of year, this period. And research is still being done, but have slowed down considerably as to what was being done between the early 90s until 2001. So what we're looking at here, let's say from an adult, getting adult donor to pediatric recipient, we would use remove the left lobe because of the recipient being much smaller, and our right lobe would be used for an adult-to-adult live donor transplant. So how the surgeon would make the divisions would be all come down to the Couinaud anatomical classifications. We're looking at, let's say, for example, an adult, a very tiny recipient like an infant would be doing a left lateral segmentectomy, so segments 2 and 3. And if the recipient was a little bit bigger but not adult, we would do a left lobe, so segments 1, 2, 3, and 4. And if it's an adult to an average size adult recipient, would be the right lobe to segments 5, 6, 7, and 8. So pros and cons of living donations. We're looking at advantages is that we could time the surgery. So it's not going to be in the middle of the night. We could time it during a time that was optimal for everybody, the team, the recipient, the donor. Because the donors are picked at the prime of health, so it assures that the recipient receives a healthy organ. It's not going to be a marginal donor. And because the surgeries are done in 2 adjoining rooms at the same time, not at the same time, but closely one after the other, we get minimal organ preservation time and damage. The recipient doesn't have to depend solely on being on the deceased donor list. And theoretically, it could, if numbers are large enough, could increase the global pool of transplantable livers. Disadvantages of live donor transplant would be there is the inherent risk of morbidity and potential mortality to the donor. And the recipient operations, it is very technically complex because of presence of portal hypertension, for example, intra-abdominal varices, and if the recipient has had previous abdominal surgeries, and we see adhesions also there. So adhesions and intra-abdominal varices are never a good combination for the surgeon. Also more labor intensive in terms of the surgery, not so much for the recipient, but for the donor. So again, more pros and cons for the live donor himself or herself. The benefits is that there is this is altruistic, so at least in the United States, the potential donor has to know the recipient and vice versa. And we, at least where liver is concerned in this country, we are not allowing Good Samaritan donors at this point in time. So we're looking at, so a lot of times the donors are donating to either a family member or a close friend. So they get the psychological benefit that is improved post-operative outcomes for the recipient because the transplant was done early enough. However, there are risks, both physical and psychological, to the donors. So as you can see here, as knowledge about living donation started taking off, we could see that there was a sudden, a good rise here from 1997 all the way until early 2002. A lot of people, centers were embarking there, and we were the biggest center in the United States until that point in time, doing biggest program doing the most number of live donor liver transplants. And we had a donor death here January 2002, and so I think what happened here was that it did reverberate worldwide, not just nationwide, but worldwide, that a center like Mount Sinai could have a complication like this. And so all programs took a step back and reassessed their programs to see whether was it worth it to continue living donation transplants. And also centers that were thinking about starting or embarking on starting to do this procedure put a halt in their attempts to want to start a program to reevaluate. So all programs have rebounded in terms of doing transplants, live donor transplants again, but the numbers have never really caught up to where during the heyday of live donor transplants. So it's at the back of every center's minds is to see that the donor donor safety would be a priority. So as an outcome of these complications, and so we weren't the only center with a complication. Other centers did at the beginning report complications because at the point rules weren't written as to how much liver grafts could be, liver segments could be resected from the donor. So rarely, but it did happen where a donor ended up requiring a transplant also because too much of a graft was removed from that donor. So the Vancouver Forum was heard, and so what key points here was to look at that the risk to a live donor needed to be justified by a predicted acceptable recipient outcome, and that there should be similar expected outcome if the recipient received a graft from a live donor or from a deceased donor. And that there should be an overall advantage to the recipient when compared to the recipient just waiting on the deceased donor list. So part of the forum came up with recommendations that the donors needed to be evaluated for psychosocial ethical issues, their motivation for donation, especially particularly since this is voluntary surgery and the donors don't get any clinical or health benefit from donation, but rather that the donor just wants to help someone. And that the live donor has to be medically suitable. And the donor has to undergo ongoing monitoring of the well-being and the evaluation and long-term outcome of these donors. So we start off with evaluating. We see somebody in the office, evaluate to see if they need a transplant or not. And one of the things that are discussed with the patient and the patient's companions is the possibility, or to see if, to assess them if, to let them know that there is the existence of live donor liver transplants. A lot of people are aware that you can do this with kidneys, but apparently, as I'm learning, is that not many people are aware that this can also be done with liver. And so we tell these potential recipients that we would also evaluate them to see if they could be a live somebody who could be a candidate for a live donor liver transplantation. So we're looking at donor selection, recipient selection, and organ size matching here. So how do we select potential liver donors, live donors? We're looking at healthy, again, the key word here is volunteers. So no coercion should not, or any monetary benefit should not play a role here. And we're looking at, this age is arbitrary. We're looking here, we put it at between 18 to 50 years old. We can stretch it a little bit more as long as the potential donor doesn't have any obvious contraindications to voluntary surgery. We're looking also at one of the things that's making it difficult to select donors is the increasing prevalence of fatty liver in these donors. We're looking at a compatible blood type. The Rh factor doesn't play a role here. Looking at compatible body size, so because what we're thinking about is that the recipients are going to be getting a partial graft. So if we have a recipient who is significantly larger than the donor, and with the donor supplying only, let's say at the most 65, 2/3 of a full liver graft, that in terms of proportion and percentage becomes much smaller when the recipient is significantly larger or in size than the potential donor. So the donors have to be fully informed about the risks, the procedure, including what the incision looks like, what are potential risks, recovery time, and the effect on the recipient. The donors are also informed about the recipient's liver disease and what are the chances of having that original liver problem return after live donor liver transplantation. So the live donor transplant is not limited to blood relations. So over years, we've seen that there hasn't been any differences in terms of outcomes of the recipients, whether they've received a live donor graft from somebody related or not related to them. And because the Vancouver Forum, also with the Health Department, State Department in New York, is that we all use a separate donor team that advocates the safety of the donor. So this would be a team separate from the recipient's medical team. I put an asterisk here with personal medical insurance because at least at Mount Sinai, we don't require that the donors have their own medical insurance, but this may not be the case in other centers around across the country or around the world. And we just don't potentially want to think that these patients who may end up applying for their own insurance down the road may be considered as high risk by the insurance plan because they've undergone significant abdominal surgery.
Larry, is O a universal donor for livers as well as for blood?
Yes. Mm-hmm. So I mentioned that the donor advocacy team is an independent team from the recipient's caregivers. For example, if I had a patient who I'm taking care of while he's waiting for a liver transplant, and he's got a potential donor, so the donor will be seen by a different hepatologist and different team, like Priya Grewal or Jawad, for example, would end up seeing that potential donor. So that I wouldn't introduce any potential bias or coercion on that donor. So that evaluating the donor is a multidisciplinary approach involving hepatologists. Other centers may not have the luxury of having a lot of hepatologists as we do here, and so would rely on an independent physician like an internist or a family doctor or a different type of physician specialist. The potential donors also seen by the surgeon, social worker, psychiatrist, ethicist, coordinator, cardiologist. So all of this is done within a period of 42 business days, 2 consecutive business days, because a lot of our donors, if we realize, may not necessarily live close by, or they may be coming from out of state. So we would want to make it as smooth as possible in terms of their evaluation. And always, first and foremost, would be donor safety. So part of the evaluation, the donor is fully informed information on both, including recipient and recipient's potential outcome after transplant, or on another perspective is what are the chances that this recipient is going to survive the transplant and also live for how many years afterwards. At no point in time does the donor feel that he or she is being forced or being pushed to donation. After the donor has completed evaluation, the donor team meets within the next 2 weeks to see if the donor is suitable, and if the donor is considered a suitable candidate, the donor is notified, and the donor is asked to think about his or her intentions for the next 2 weeks, because we've also known that psychologically it be different from wanting to donate and being told that yes, you are a candidate and that we'd like to, you could schedule the surgery. We've had some donors get cold feet and we never hear from them again. It's unfortunately a fact of life. So during that period, what we call the cooling off period, the donor after 2 weeks calls our donor office to announce their intention. The donor team does not call the patient after 2 weeks because that would introduce a form of coercion also, or the donor may feel like they don't have the chance to say no or to postpone the decision making. So we tell them that after 2 weeks, call back. You could tell us if it's a yes or a no, or if you want some more time. Because as pointed out, living donor transplant is not performed in recipients who need urgent liver transplantation. So there is that luxury of a little waiting time for the donor. And the donor may opt to decline surgery at any time. We'll tell them even after they're being wheeled to the operating room, as long as they haven't signed consent yet, they can opt out any time. And this gets a little tricky because we also don't want, let's say the donor opted out, and we don't leave it for the donor to explain to the potential recipient or the family that why the donor opted to back out. So the donor team will come up with a medical reason why the donor is not considered a suitable candidate. So part of the 2-day evaluation includes a full panel of laboratory tests, and also what we want to look at would be the anatomical makeup of the donor's hepatobiliary system. So different programs will have different ways. We could use, for example, a CT or MRI, angiogram, MRCPs, different ways of looking at. What we're looking at is the volume of the liver and looking at also if there are any presence of biliary or vascular anomalies or variations, which might prevent or make the transplant surgery difficult. A liver biopsy is not mandatory. Sometimes we may request it. Some centers may want it. And there has to be a specific reason why we want to have the biopsy, but it's not mandatory for the donor's evaluation. So in selecting a recipient who may be a candidate for a living donation, we're looking at organ size matching. So I talked about body size matching and also a compatible blood type. And so whether the donor recipient is Rh positive or Rh negative doesn't come into play. We're just looking at the letters A, O, B, or AB. We're looking at also the degree of existing portal hypertension, because the more portal hypertension there is in the recipient, the surgeon can anticipate having more difficulty during the operation, and if there inherently are high complications for perioperative morbidity, then a leg donor transplant may not be the best way to go for the recipient. I mentioned about doing abdominal imaging to look at variations, looking at the anatomy of the biliary system and the vascular system because of variations, congenital or natural variations in anatomy. And also looking at both the recipient and donor, also if they've had previous abdominal surgery, to see if that comes into play about complications, such as the presence of adhesions in both the recipient and the donor. MELD score comes into play. So we're looking at, and this would be the natural MELD score and not any of those scores where people get priority, for example, for liver cancer. But we're looking at the higher the MELD score is, the more chances that the recipient is going to need a whole liver rather than a partial liver, because a partial liver may not work very quickly in time for that recipient to have a good outcome after transplant. So over here at Mount Sinai, we use a cutoff score of 25, a MELD sodium score of 25, so natural score, so nothing that's contributed by other variables such as taking warfarin to it, which would increase their INR, but doesn't really reflect the degree of liver dysfunction. So I mentioned earlier about the segments that are used, so from adult to a very small small recipient, a little larger recipient, and adult-sized recipient. What we're trying to avoid here is a phenomenon called small for size syndrome, where the recipient received a graft that was too small and it doesn't work right away and ends up becoming a hindrance or could affect the recipient's life rather than helping to enhance it. So we're looking at how do we figure out the size besides just eyeballing the recipient and the donor. We're looking at, so we have to do things a little more objectively. So we can, the transplant world's come up with different formulas. So one of the things with looking at, let's say the graft, the donor's estimated graft weight. So this is after doing abdominal imaging, looking at the volume, and the surgeons figuring out where they would make the resection to separate the donor, what's left in the donor, and what goes into the recipient. So the graft weight of the donor, potential donor, to the recipient, we're looking at this ratio has to be greater than 0.8. We're also looking at the donor graft weight and the standard recipient liver volume ratio. Again, the degree of portal hypertension comes into play because with less portal hypertension, there's less graft weight needed to be given to the recipient. So this is a site. So we're looking at, can all people who want to be donors become liver donors? And so this is a study that was done in Denver. And so they followed, and Denver is doing a lot of live donor transplants. So they're looking at 100 pairs of recipients and donors, and came out at the end that only about 15% of these pairs actually were able to undergo live donor liver transplantation. So we asked potential recipients who have potential donors that if you have more than one donor, we're not just going to limit you to just having one donor evaluated. I mean, we can't evaluate more than one donor at a time, but we ask recipients who have more than one potential donor is to just give all the names, have them all call the donor office, and then if, let's say, the first donor's evaluation didn't work out, the donor office would just automatically call the second potential donor and work down the list. Just so that there isn't much more time, more delay in terms of getting the patient to a transplant. So technical consideration, I mentioned about vascular and biliary variations. So we can have about 20% of the time, the donor, we as a whole can have anomalies or variations in our vascular anatomy where the hepatic and portal vasculature is concerned, and also with bile duct. So we have to see how the surgeon would have to look to see how they would be able to connect these vessels from the donor to the recipient. So there are times when the donor looks rather suitable, except that because of these anomalies or anatomical variations, that it would be very difficult to predict a good, difficult to have a good outcome for the recipient because of these anatomical variations, and so the donors end up being eliminated as candidates. We explained to the donor that the operation would probably take between 4 to 8 hours, that even if they're just having the left hepatic lobe removed, they may, and even more so with the right hepatic lobe being removed, is that the gallbladder is often removed in the interest of time. The gallbladder technically, in theory, could be left there, but that would add up more hours in the operating room and probably increase the potential, the donor's perioperative morbidity. Blood transfusions are not mandatory, but might happen, so we look at donors who are able to accept blood products. And then there's also the question of the middle hepatic vein of who gets to keep it, the recipient or the donor. So it's still up in the air. There are different schools of thought, so there's no right or wrong answer of who gets to keep this vein. So for the recipient, we talked about complications, anatomical content, and surgical surgery is more complex than with deceased donor graft use because what's being implanted is just a partial organ and not rather not a whole organ. So it's not going to be a let's just reconnect things where we left things off, but rather they may have to create some new connections. Immunosuppression. In the beginning, there was a thought that since the recipient's receiving only partial liver, maybe the recipient doesn't need so much immunosuppression in the beginning. And so there were centers that used lower calcineurin inhibitor doses in the beginning, and some kept the same ones. And we found out through the years that really doesn't make a difference whether the recipient received a whole organ or a partial organ, is that the amount of immunosuppression seemed to be about the same for recipients of both types of grafts. So the reason how living donation came about is that knowledge that a normal liver regenerates. If you resect, as long as you don't cross the boundaries, if you resect just enough liver, a normal liver will regenerate. And so this has been the key to success for live donor transplant. And it begins immediately, so within the first 24 hours, we'll see all the biochemical parameters for both the recipient and the donor are both getting better spontaneously. And that remodeling may take up to a year. So this study by Marcus back in the late 1990s, and these are MRI studies looking at donor recipients. So they looked at 31 donors, and this is looking at the initial mass. So the donor's left with this amount, and the recipient gets this amount from the donor, and then following it all over across time. So in the beginning, we could see that within a week, we already see a significant increase in both the donor and recipient's existing liver masses. And then this continues all the way until we get a complete regeneration, so a complete size. So donors sometimes ask, can I donate again after this one? And we say, in theory, yes, because you've got a 100% size liver, but in reality, no, because your internal architecture is so different that the surgeons are going to will have major difficulty in knowing where to resect your liver. So donor complications, I mentioned earlier that in the beginning, rules weren't written. We didn't know how much to remove. So some of the donors ended up having complications because too much of the liver was removed from them. So complication rates can range from none to about 2/3 of the time. 2/3. Most complications are minor. So we used the Clavion surgical risk of complications. So we're looking minor complications, meaning class 1 and class 2. And the bigger the amount resected, the higher chances that we would expect some kind of morbidity or mortality if that occurs at all. And again, this is voluntary surgery. It's all altruistic. The traditional surgical endpoints, such as having your inflamed appendix removed, will make you feel better. It doesn't apply to our liver donors. So these are breakdown complications. Most common complications we'll see in live donors would be biliary, and remote but possible chance that death can occur. So for the donor follow-up, standard guidelines in somebody recovering from surgery is not determined. We still don't know what the answer is. How long do we need to follow the donor? I think Priya here with Priya's left. I think with the donors, we follow them up to 2 years here. And from then, it's phone calls to follow up on these donors once a year. 1 year after the donor has the surgery, the donation surgery, we do imaging just to confirm that the liver has grown back to 100%, although we would suspect that early on because of just the biochemical improvement and resolution of any temporary abnormal biochemical abnormalities right after surgery. And then there's a need, because we don't know if the donors have any particular issues that related to their transplant compared to anyone who's had any kind of abnormal surgery. Long-term assessment of these donors would be needed. So I'm looking here, the next 2 slides are just comparing what the survival rates are between somebody who's received a graft from a deceased donor and somebody who's received a graft from a live donor. So this would be what we normally would see. Things haven't really changed in terms of the outcome, even though this data is from 2007. And so we're looking here at live donors. So we see a significant difference in terms of survival. And one of the things here would be early transplant time. So I was talking to some of the fellows earlier this week about, since last year we've been doing transplants, giving HIV positive organs to HIV positive recipients, and transplanting them at MELD scores much lower than what we normally would do. So here in New York, let's say the average MELD score we transplant people would be a score of 30. So we're transplanting our HIV recipients with HIV organs with MELD scores of 15, 17. So we're seeing good outcomes. They leave the hospital a week after transplant. They go straight home. They don't go to subacute rehab for more therapy. same thing we're seeing in patients who are receiving deceased donor grafts, patients with a blood type AB, which comprises the shortest list, at least in our region, and probably goes across all other regions in the country. And so I had a patient yesterday who got a transplant, blood type AB with a MELD score of 17. He's already awake, even though he has the breathing tube. He's awake and waving his hands already. So the same thing probably would apply to patients who get live donor liver transplant. You can plan it much earlier. Also, at the same time, is this potential group that would benefit from this is a group of recipients who are, in theory, in reality, very sick and have a lot of complications. But unfortunately, some of these patients' complications don't translate to a rise in the MELD score. So this would be where patients could benefit much more. Also, patients who have hepatocellular cancer, whose natural scores don't really go up and have to wait at least 1.5 years to 2 years in the New York region for a deceased donor graft. So the numbers look good. The temptation here is just that we're only human. Sometimes we may want to exceed the boundaries of where transplant is because the patient has a donor. So we always have to take a step back and constantly review the situation, whether is the recipient going to survive longer if they go for, let's say they have a live donor, or maybe they have a condition in their liver where even though they have a live donor and have a transplant early on, that their outcome may not be as good. So, and we always have to remember that safety of the donor, whether it's the donor's ability to undergo surgery, is it going to be worth that kind of risk. So financial aspects, so I mentioned earlier about we don't expect, at least in Mount Sinai, we don't expect our donors to have their own medical insurance. So what happens is that the recipient's insurance pays for our donor's surgery. And so approximately how much would it cost? Cost within a week surgery and hospital stay would go between $350,000 to $500,000. And then in terms of that, so I talked about this one. And cost-wise, in the United States, healthcare is much more expensive than a lot of large parts of the world. So these are some of the other costs that are available outside. Again, this is not something where I would promote medical tourism in this aspect, because we're looking at donors who need to have some kind of relationship with the potential recipient. So points for consideration here, things that have come up, but which are in their infancy and look good on paper, would be minimal invasive donor hepatectomy. So this is being done for kidney donors. But because of the larger vessels and the complicated vasculature with livers, is that this looks good on paper, but in reality is not ready for prime time. Expanding the live donor pool, so it's a little like transplant is, to me, a positive take on science fiction. Something I never expected, that, replacing body parts. So we're looking at whether, and so there have been a few rare instances where the potential donors may have the recipient needs a right lobe, but the potential donors coming forward have right lobes that are too small, and the left lobe is a little big, but not big enough to give to donate to the recipient. So dual graft has come about in a few cases where you have two separate donors, and so you take a little bit of here, a little bit of left, a little bit of the right. So it is successful, but it's not recommended at this point in time, just because, well, it's hard to find one suitable donor, and second is just the risk of putting two people at this type of a risk for voluntary surgery. ABO incompatible live donor transplants, it's been done for deceased donor because of just the medical urgency, because live donation is the urgency is not as high as in somebody needing a deceased donor. This is also something that is being looked at right now, but not being carried out in a regular manner. And also the thought is that perhaps with not just staying within the Milan criteria for hepatocellular cancer inclusion criteria for transplant, but looking at other types of criteria like the UCSF criteria. Major challenges still remain. Organ shortage, we haven't really answered that. Further studies on donor outcome creation and continuance of international donor registry, and then knowledge also treating the recipients, because recurrence of the risk of recurrence of the original liver disease or malignancy. So because of the need for research, there is a consortium, so the adult A2ALL, or the adult-to-adult live liver surgery consortium. So this is under NIH support. So we're looking at the donor-recipient outcomes after live donor transplant. So we're looking. So these are some of the things to look at. The next few slides, I'm just going to point out the salient features of some of these studies that have come up, which summarizes our knowledge of live donor liver transplant at this point in time. So the overall result of this consortium is that live donor transplant remains a viable option, and that the outcomes improve as long as the center's experience in doing this type of surgery increases to at least gets to a minimum level, and then is constantly increasing, or at least staying at a steady level. So survival found that when done, when recipients are chosen carefully, is that there is no significant survival difference in recipients receiving donors from deceased, receiving organs from deceased donors versus those receiving organs from live donors. And that the important predictors of graft loss in these recipients would be the center having limited live donor liver transplant experience. So we're looking at those doing less than a total number of 20 cases. The pre-transplant liver hepatocellular cancer, and then the MELD score at the time of transplant. So the higher the MELD sodium score, the worse the outcome in those who undergo live donor liver transplantation. In terms of HCC, those recipients, so this I think came about probably like, I have a recipient, the recipient has a potential donor. Maybe the lines get a little blurred in choosing which recipients, which patients can go on the liver transplant list based on the HCC. So there was a higher rate of the recipients having HCC recurrence within 3 years, but the good thing is that there was no difference seen in the recipients' mortality rates.
So did they think that the higher rate was because the regenerating liver was a more fertile ground for HCC to take hold?
Yeah, they haven't gone into that in these papers. Yeah, but that's a thought, that now you have a working liver, yeah, as opposed to a liver taken up by fibrotic tissue.
Would you see that iron in the donors also?
Iron in the donors.
Iron in the donors because they also have such high regeneration.
No, yeah, I mean we haven't.
Because the donors wouldn't have any circulating tumor cells. So I assume that the comparison, the p-value is the comparison of if you're a live donor recipient or a deceased donor recipient. So in both cases, you wouldn't have fibrosis in the graft, right?
No, in
so
the
the
recipients.
difference really is that in one case you've got a regenerating liver, and in the other you have less regenerating.
In terms of at the beginning.
Yeah.
Yeah,
so
because you have a whole liver versus a partial.
Does that milieu
of regeneration does it become a stimulus?
Favor.
Yeah, that's a thought. So looking here, done early enough. So recipients of live donor liver transplants is associated with lower recipient mortality. Again, we always have to weigh the pros and cons regarding the live donor, the donor himself or herself, to see if is having the donor undergo this type of surgery worth it in terms of the outcome to the recipient. So complications can occur, but thankfully most of them are minor. So most of these are not wholly life-threatening, and it just brings down the fact that we should always have the donor's safety in mind at all times, and that complications tended to occur in those centers who were still starting to learn how to do live donor transplants, as opposed to those who've already gone through a minimum number and are having a steady or increasing rate of doing these surgical procedures. Graft rejection, there was a thought in the beginning that maybe using a live donor, a donor who was related by blood, would result in less chances of rejection because of similar immunologic makeup compared to a donor who was not related by blood. But over years, we've known that we've observed that there really is no difference between getting a graft from a live donor who was either related by blood or non-related at all. And at this point, there's no current protocol recommended to support using a unique immunosuppression regimen for recipients early on or even afterwards who've received grafts from live donors. So the psychiatric issues, these have to do with the donors, and then found that a small percentage, but still existing, had psychiatric complications after liver donation, 3 cases of which were severe enough, and that, which is why, at least here at Mount Sinai, we have the psychiatrists evaluate the potential donor before donation, and there's also follow-up afterwards to see if there are any signals or any signs that the donor may not be coping well or having difficulty adjusting after the surgical procedure. So this is my last slide. So just a summary of take-home points would be that live donor exists as an option for eligible patients. Surgery itself for the recipient will be more complex than the standard deceased donor liver transplant because of use of a partial graft as opposed to a whole graft. Donor safety should remain a priority, that the outcome of a recipient from a live donor graft is just as good as receiving a graft from a deceased donor, as long as parameters are not, boundaries are not exceeded, and that the monitoring of both long-term donor and recipient outcomes would be necessary. So,
Thanks, questions?
Yes. Does gender matching have an effect on outcome?
No. In the beginning, also, those things were all explored to see if there would be. Thankfully, no differences were seen.
Larry, I wanted to hear your thoughts on why do you think in the U.S. we are not doing more live donor transplants? Like, what's really happening? Why are we not doing like some of the centers in, like, for example, Turkey? They do 400 transplants a year in one center. I know some of our centers do below like 10 transplants a year.
Yeah, I think it's multifactorial. One is that we have a established like agency, UNOS, to allocate organs across within the region and across the country. Second probably would be, and this is not according to incidents. Second is, I think one of the advantages of having such a big and variable country is also people coming from different walks of life, different cultural backgrounds, religious backgrounds, and so some people may not be very open to the idea of giving up a piece of their body parts to someone else. Third is the donor deaths, and also, let's say, in this country, in terms of litigation. So that's making a lot of transplant centers really think very carefully about before embarking on something, doing more live donor transplant surgeries. Just at least a few reasons I can think of off the top of my head why we haven't really taken off. Fourth probably is the difficulty in finding suitable donors. Again, we're coming from a culture where a nuclear family or close-knit family is not the norm, or is not the majority. So I think for a lot of us, even just evaluating somebody for a liver transplant, we're having trouble sometimes finding social supports for that recipient. So finding somebody who actually wants to give a piece of the liver is probably even much less. I think another reason would be the advent of fatty liver disease or things. I think that's been a major drawback in eliminating potential donors. We're seeing a lot more people coming forward, but we're finding a lot, percentage-wise, a lot more people, potential donors with fatty livers.
But I think it looks like the legal system has a major impact, right? Because I think they're putting too much pressure, right? Don't you think that's one of the major?
Yeah, I mean, there is. I mean, if you think about it, we're putting somebody who doesn't need surgery into this kind of a risk, and so the logical thing would be, why don't we work with the current system and try to correct it? I mean, the deceased donor system, and try to correct it before we bring in a third party in, and subject them to potential risks.
There's something to that, because in Japan they don't do any deceased donations, so there's a pressure to call on live. So here there is a pool.
But I guess the problem here also is 16,000 people waiting and only 6,000 get a transplant. So
Yeah, and it's actually also surprising. I don't know if anyone's done this. I've done this in office a few times. So when patients come in and on the waiting list and they wait and they wait and they wait. And I ask their family members if they themselves have signed up to be organ donors, and the answer is a big fat no. And so I don't understand the disconnect there. You come in here, yeah, I don't know, you could try that as an experiment and see how many people have signed up to be organ donors. You get, it's a low number.
Do you see any trends here in Mount Sinai as a disease process that you're more likely to pursue a living donor in our patient population?
The HCCs, yeah. And I think also...
Yeah, as a follow-up to that question, so one clinical scenario which I find sort of troubling for living donation is you have a patient who has a donor, and let's say they're borderline in terms of their T2 Milan criteria stage, maybe a 4 centimeter and a 1 or 0.9 sub-centimeter tumor, and kind of time is of the essence to try to get this patient transplanted, perhaps for a durable cure of their HCC. In deceased donation, you'd require a 6-month waiting period.
You have to drop out.
If you had a hugely available donor pool to see if patients will sort of wash out in sort of high risk biology kind of situations. So, how would you tackle a situation like that in terms of you had someone who was a good candidate for a transplant, but sort of has this borderline HCC?
Yeah, and that's always this becomes where I guess being human comes in, where we entered into this particular profession because we want to help people. But again, you have to weigh out the donor safety, and until we come up with better ways of stratifying the risk of that HCC recurring, such as genomics, going just beyond histologies to help stratify it, and help educate both recipient and potential donor about the risks of this cancer coming back, if it comes back at all. Because we've had patients, even with deceased donors, we've had patients where their explants show there's a high chance it's going to come back, macrovascular, and it never comes back. So I think we're not ready for, unfortunately, like going beyond just the criteria we're using to allocate, where HCC is concerned, where liver transplant eligibility is concerned.
Currently, we don't have a protocol that would require this kind of situation to have a 1, 3 month, 6 month type of waiting period.
Yeah, for the live donors, yeah, we don't. So we have to just follow our protocol that for a person to be eligible for live donor liver transplant is they have to fall within the criteria of being eligible for a deceased donor transplant.
Any other questions?
Is there any experience with domino liver transplant here?
For live donor, we have, and the one we come the closest would be things, the domino transplant like we use for familial amyloid polyneuropathy.
So
Yeah, we've done a few.
Outside of you don't need here, which is actually a very high number.
Yeah,
We have the most experience with it, so.
We've also done live donors with identical twins. So that's always a good thing, because then as long as we've proven phenotypically, genotypically they're identical, these recipients don't need immunosuppression at all. So I think we have, 5 pairs of identical twins.
Wasn't it here? Last question. Sorry,
So 2 weeks of cooling off time can be waived.
Can be waived? No, we can't. Yeah. It's different if you're going to have a parent-to-child bond, like a parent and the recipient is a pediatric patient. We can waive that because it's more urgent, and there's always a stronger bond between a parent to a child. Well, traditionally, of course, boundaries are going to change. Traditionally, it's always been a mother to a child. It could be a father to a child, but yeah, those are the few times where we waive the 2 week.
Okay, thanks again, Larry. That was great.